Welcome to the ISHLT Pulmonology Professional Community webinar. The 10 ISHLT professional communities are the gathering place for the professional specialties that make up the care teams for our patients. Each ISHLT professional community is represented on the 4 ISHLT interdisciplinary steering committees: advanced heart failure and transplantation, advanced lung failure and transplantation, mechanical circulatory support, and pulmonary vascular disease, CTEPH and PAH. The ISHLT professional community webinars are free and open to all with an interest. If you're not a member of ISHLT, please consider joining this unique international interdisciplinary society. If you're already a member, thank you for making this organization what it is. If you'd like to join or get more involved in ISHLT, you can contact anyone at ISHLT headquarters through the website. Good morning, good evening, good afternoon, wherever you are. We have a webinar today titled Donor Lung Acceptance and Recipient-Donor Matching. This will be a debate between 4 outstanding speakers, giving the different specialties perspectives on donor and recipient matching and who is best to make the decision for donor acceptance. Our first speaker is Dr. Brian Whitson, who is a cardiothoracic surgeon at Ohio State University in Columbus, Ohio, United States. So I will turn this over to Dr. Whitson.
Thank you, Dr. Hatcham, and I like to thank the Society for the privilege of being able to represent surgeons. So hopefully I can put together a cogent argument for the group of why surgeons should at least be part of the conversation, if not a big contributor to donor-recipient matching. So I have a slide that I'll share with you, and I think some of these things that I'll talk with the group here in big concepts, but the things that I think about, my partners think about when we start looking at donor and recipient matching, a lot of it comes down to 3 big buckets of donor factors, recipient factors, and also transplant factors. And none of these in and of themselves are probably super hard concepts to grasp, but some of their interplay can have some nuance to it. And there is probably some art to it, maybe a little bit of science around some of the size matching. And I'll walk you through at least things that I think about and my partners think about here at Ohio State. So we start thinking about some of the things that are donor factors. Some of these are things that are modifiable. Some of these things that are not modifiable. Some of them are just the physiology of the donor, of whether they are somebody with polytrauma, whether they are super tall or super short in stature. Those are some of the things that we can't change. BMI, we can't change. However, what has happened to the donor and what their body habitus is, sometimes are things that can be managed. And some of the things that jump out to us that we've had really good luck with over time that is nuanced, that does take a bit of an art in terms of how to manage the donor and how to assess it intraoperatively, are the impact of body mass index or the morbidly obese donor, or those donors that may have a modest amount of effusions, or how we manage recruitment. So sometimes the things that when we look at, and we look at blood gases, look at chest x-ray, CT scans, and something just doesn't seem right. You know, you have a young donor who may be 18, 20 years of age, and they unfortunately had a gunshot to the head, but the gases are very poor, and something just doesn't make sense based on the CT scan, doesn't look like they've aspirated. And oftentimes, if the story seems compelling, we have capacity, we'll go take a look and find what can be addressed and made better intraoperatively. Those may be things that mucus plugging or endotracheal tubes that may have migrated and become main-stemmed, things that are maybe more mechanical in nature that until there's somebody hands-on on site, don't know whether it's able to be recovered from or not. Similarly, in our more obese donor and also those donors that may have modest effusions, those initial gases that may dissuade some people just by looking at raw numbers from going to take a look oftentimes, if it's a compelling story, again, you have to kind of take this in context of what the donor may have passed from, of whether or not there's something that can be recoverable or not, and you start putting DCD recoveries superimposed on that, there becomes a lot of nuance. There are inevitably recipient factors that have to get matched to that donor. Thoracic cavity sizing is a really important one. We have found and are working through the data to support this, that a modestly oversized or same-sized recipient to donor match for somebody with pulmonary fibrosis will do well over time as the diaphragms re-recruit and the thoracic cavity expands. There is a bit of nuance to that, and also figuring out whether there is any restrictive chest physiology for somebody who might have a true restrictive lung disease or something like scleroderma, and trying to balance those comorbidities of the recipient and what we think they may be able to tolerate or not. And then the inherent nature of whether something would be a redo or either redo transplant or redo thoracic surgery that might have a higher likelihood of bleeding or reperfusion injury or need for mechanical circulatory support. So these are all recipient things that we try to take into account. A intangible part that is, again, somewhat nuanced and it's very situational dependent is what are the transplant factors? So what time is the donor OR being set for? Do we have ability to have a team go and take a look or not? Are we reliant on local resource that we may know or we may not know? Are there operative concerns in terms of hostile chest cavities, either in the donor or the recipient? How long do we think it's going to take to get either the recipient ready or the donor ready? What's the abdominal team? What are they doing? Are they taking pancreas, intestine, or is it just a liver or the like? And whether they're a DCD donor, and if they're a DCD donor, what are the time constraints? Do we have the ability to do ex vivo perfusion to resuscitate and assess the organ if it's a protracted agonal or ischemic time? All these things, these come into play. And I think the way that I like to dumb it down, at least for the surgeon's perspective, is that we can balance it of having a negative, so whether that's a marginal or extended criteria donor or a marginal recipient that may be on ECMO or redo, and having one of those be in that marginal or high risk category probably can end up with a positive outcome. Having both of those be marginal or high risk is really hard to recover from and really takes a lot of good luck. And so all of these moving parts and things that particularly start thinking about how to assess and resuscitate a donor in the operating room, those are things that I think are probably more inherent to what surgeons are more used to doing. And we started thinking about capacity to expand donor pools and be very aggressive in our assessment of donors. I think that's where the surgeons have a very important part, because some of the things that we assess, at least through DonorNet, or limited ability to do active event management, depending on the situation, whether it's a DCD setting where we're not able to do really anything at all, or if it's in a recovery center or in a small hospital that really doesn't have any type of critical care capacity to do any donor recruitment. A lot of that is incumbent on things that we can do in the operating room. And I think in that setting, the surgeons probably have a little more experience and nuance around some of those modifiable things. And so all that put in context, I would make the argument that surgeons need to have a substantive role, if not major role, in some of the donor recipient matching. So I will there turn it over to Dr. Hatcham.
Thank you very much, Dr. Whitson. Very good insights on the surgeon's perspective. Next, we have Dr. Greg Snell, who is from Melbourne, Australia, who will provide the pulmonologist's perspective and argue that the pulmonologist is best at making this determination.
Thank you, Ranty. The case will be made as to why the physicians should be the person who is essentially controlling the donor and recipient matching. I think Brian has clearly made my case. So I'll, with no further ado, I'll jump into it. Lung transplantation is the intention to treat therapy from the time of referral, not assessment, not listing, not lung transplant. We're aiming to take a patient who we see and take them right through out the other side for as long as possible. There are mortality implications of being referred or listed for transplant. It's a very real risk that you're going to die, and the biggest risk is of not getting a transplant. And the donor marginality, quality, and the surgical factors have much less impact. And we must remember, we literally made up all these donor and recipient quality rules that we use. They've all been broken over time, and they will continue to be broken. So therefore, the aim of a lung transplant is the maximum number of lung transplants, optimizing the marginality and the donor or recipient matching with that, with the best long-term intention to treat survival. And I think too much is made of the last-minute ECMO planning, and I believe that ECMO is essentially a failure of good planning in the time beforehand. And I'd arguably say that the plasmapheresis is also something that if you can list the patient earlier and get into things earlier, you won't necessarily have to go against the cross-match. ECMO as an intention to treat is a bad idea, particularly if the referral is a Friday night referral to your intensive care unit to see someone who's on ECMO, or they need a transplant this weekend. That has very poor outcomes in terms of they die on the waiting list and they get transplanted and they still don't do as well. And a calm measured on the waiting list and gets a transplant with ECMO is the way to go. There's two graphs here. One is intention to treat survival from lung transplant listing without a transplant, and the other one is with a transplant. And essentially what you want to do is get from one curve to the other curve. The LAS tertiles do tell you who's going to die over the next sort of year or so, and you can see that you have many people will die on your waiting list if they're not transplanted. But once you actually get a transplant, the LAS score makes no difference to the sort of 3, 4, 5 year survival, as you can see. And so the main point about getting from pre-transplant to post-transplant is surviving over the time, over a period of years, is to actually getting the transplant, getting from one curve to the next curve. So the physician matching, you match the blood group, you aim to do the sickest. You need to know the exact status of every listed patient. You have to have attended the meeting, Brian. You aim to do this, the highest PRA patient you possibly can. You try and do 2 single lungs if the donor quality allows. You use all the information you've got to achieve that. You consider the cut downs. You consider an extra large lung on the right because you've got extra space and can push the heart out of the way. You can undersize a bilateral lung transplant. You've got the virtual cross match, including consideration of the related groups and eplet matching. You can escalate to prospective flow cross-match, retrospective flow cross-match, and this can inform decisions on plasmapheresis and IVIG. You get a chance to optimize the donor physiology and antibiotics before the surgeon's in the picture. The surgeon tends to make a decision and say yes, no, but you actually get a chance to improve the situation and put as a package then that you can work with. You need to consider which surgeon you've got working. The OR's sort of basic, how clogged it is with heart transplants. You need to be considering the skills of the whole team. What you're at, what did you do yesterday? How many other cases are coming up that you know about? The logistics are important. Getting aircraft to places to get organs, planning whether you can do a DCD on a recipient that you're going to move back to your centre, multi-organ transplants. You need backups. Left lungs, right lungs, are you really doing the heart lung or the one with the kidney? So it's important not to involve the surgeon too early and confuse them because they'll talk you out of it. And you can be innovative. There are quite a number of things you can do that we just make up at the time to get aircraft, to get recipients, to get cross-matching done and to actually improve organs. When I'm talking about donor quality, I think the categories have widened. Age less than 75 years, PF ratio needs to be more than 250. Increasingly getting concerned about marijuana, which is 6-fold more likely to have airflow obstruction than a cigarette. You can accept abnormal chest x-rays and CT scans, and indeed 80% of our cases have an abnormal chest x-ray or CT scan. And there are a lot of other things there that are just routinely not a problem. Unacceptable is even a young donor who's got marijuana with cavities on the CT scan. Higher smoking pack years, you can get into trouble, and where you've got changes in both lungs, that are particularly those that are diffuse. And if you take smokers, yes, you do not so good if you've got an ever smoker versus a never smoker. But the bottom line is that you've got patients alive 3 years out versus, as we saw, a very high mortality. And if you look at our own figures here, if you wait for that perfect donor, you lose more on the waiting list. That's the ISHLTv registry. Is much more, is 5 times worse than our 5% waiting list mortality. And you don't have as good a transplant at the other side, so your early mortality is not as good, and you basically stacked yourself with organs that aren't as good. So you're better to jump in and get across that line. Transplant is the answer. And despite that, and if you're doing that, you actually achieve greater per million population than if you're conservative. And my other speakers are categories 3, columns 3 and columns 5. I think that also answers where the surgeons and the coordinators should be. And I don't see a box of any country there that's doing artificial intelligence, pardon me. So the physician matching, in summary, is the total overview, the total package. Now let's look at surgeon matching. They consider the blood group, they consider oversized cut sounds, they consider the team and the case. But it's absolutely clear, and my subsequent slides will show, they're best left sleeping. They don't wear the waiting list. They don't do immunology. They don't have that long-term clinic and utility in mind. They miss the meeting. And they can be surgically innovative, but they can't do the whole package. So this is Brian's team. They're exhausted because they've been up all night trying to sort out the donor. The EVLP machine's in the back, and they just haven't made it. He's actually got a little confused. This is a picture of Brian I found, and these are not lungs, Brian. He's sad because it hasn't quite gone as well as he thought, and he didn't get the organs. And at the end of the day, he's a little confused with what to do next. So the summary is, it's a historical small picture of lung transplantation. Very valuable, but small picture. So the coordinators, they can match the blood group, they can do the sickest patient, they can know who's on the list, they can organise the logistics, they can help the surgeon and the physician sleep, but they don't know the medical donor and recipient nuances. We work with some very obscure diseases. They can't push the ICU donor optimisation as a physician can. They don't do immunology, but they can be administratively innovative. So there's Brian, a transplant coordinator, not a magician, but you can see that he might be confused. He is a little confused because there he is looking at a chest x-ray backwards, looking a bit frustrated. And finally, there's Brian sad at the end of a night's work with a headache. So absolutely got the practical viewpoint, but it's the small picture. So let's talk about AI. No, let's not. No way, that's never going to work. It's too complicated, it's too nuanced, and the more experienced, the better it goes. So in summary, it's all about intention to treat from referral. Matching is very complicated, best done by physicians. Donor lungs work, so use them more often than you've been using them, and you can save lives and be innovative and creative, because that's the best fun of this whole job. Thanks for the opportunity to talk.
Thank you, Greg. That was very insightful and entertaining. Our next speaker is Paul Lincoln from Papworth Hospital in England. So Paul, please go ahead.
Thank you very much. Well, I don't really know how to follow that. That's I would like to say that's put me in my place, but I'm not going to. So why is the transplant coordinator the person to be involved? Well, nursing's changed, and certainly from the British perspective. Obviously, I don't work in Australia, or in the States, so I can only talk about it from the UK perspective. And the number of tasks that are being undertaken by nurses now has increased, and we have become a much more skilled workforce across the world. And we are talking here about the specialist nurses that work within transplantation, and we have these 4 main work domains that have been identified by the Nursing and Midwifery Council that have come about since 2010. So this is us working as nurses working at an advanced level using complex reasoning, critical thinking, reflection and analysis to inform our assessments, clinical judgments and decisions. we can apply our knowledge and our skills to a wide range of situations. So I'm not sure that I'm as confused as our last speaker would have had you believe. Transplant coordinators, we have knowledge and insight into the entire pathway. We are the first point of contact. When the patient is referred, the first person they speak to in our centre is a coordinator. The person that sees them when they come to clinic is a coordinator. The person that's there when they get transplanted is a coordinator. The person that sees them in clinics after the transplant is the specialist nurses or the coordinators. So whilst I appreciate that our medical colleagues have a part to play in the entire role, I would argue that the advanced nursing team do also. We have a high level of expertise in the patient group which we care for. We've got additional qualifications, our clinical assessment skills, our non-medical prescribing skills. We have specialist nurses that go out as part of our retrieval team, and their job is to optimize the donor in the hospital. So there is a nursing team that also are capable of doing that and can communicate with us and liaise with us to make sure that the donor is being optimized appropriately. We've got a wide-ranging knowledge of the healthcare organizations that we work for, plus the other organizations that we use and utilize to try to ensure good transplantation. To give you a little bit of an idea as to why I think that the coordinator is a good idea, I think you need to look at the process that occurs in the UK and how the donation and the offering sequence happens. So a donor is identified and is registered with the NHSBT Central Hub operations, and then a named offer goes out to all appropriate super urgent heart and super urgent lung registered patients. Following on from that, if the organs haven't been utilised, then it goes on a named offering sequence for urgent hearts and urgent lungs for registered patients. And then finally, if it's still not been utilised, then it goes out as a group offer, and it comes out to offer for patients on our routine list. So this will be a heart-lung block, and then hearts, and then lungs, dependent on what's been accepted. So the upshot of this is one donor can generate 6 offers through the night. So you can have a named urgent, super urgent, named super urgent lung, a named urgent heart, a named urgent lung, a group heart and a group lung, all from the same donor. So that's 6 offers from the same donor in one night. If we look at the decline rates that are in the UK at the moment, they are high. So that would back up the argument that perhaps surgeons, which is where I think most of ours discussions go on at the moment, are not necessarily the right people to make the decision regarding accepting organs. I looked at the donor offers that came to Papworth in 2021 to 2022, and we've got a low yield from the number of donor offers that we received. So we received 1,328 donor offers, 179 were accepted and 74 were transplanted. The majority of these happen out of hours. So this means that we're looking at, in a year, only 13.5% of all offers were accepted. 41% of those went on to be transplanted, but in total, only 5.5% of all offers resulted in a transplant. So obviously, we need to be looking perhaps more at how we're accepting offers. Royal Papworth has a protocolized process, so a bit similar to my the last speaker. So the transplant coordinator is contacted directly by NHSBT hub operations, and this is by telephone with a named offer or by email if it's a group offer. The offer is then reviewed. The coordinator will then look against the waiting list to see what we've got in the way of compatibility with ABO blood typing and appropriate size range that's been set out. When the patient was listed, there is a size compatibility that is a size range that is registered on the waiting list. We contact the on-call tissue typing department, and they will check against any suitable recipients that have HLA issues and tell us whether or not it's safe for us to proceed with transplantation. At that point, we discuss with a consultant surgeon, because at that point we'll know whether we've got any suitable recipients for these organs. At that point, our following discussion with the surgeons, we then contact the hub with the decision. We have 45 minutes to get that turnaround. We did a 3-month audit of the lung offers that we'd received at our centre. And you can see from this, 183 offers were declined out of 257 that we received. When you look at the reasons for declining, 66 were history, 51 were function, 45 were no suitable recipient, either based on sizing, ABO blood group, or tissue typing. 4 patients were declined on radiology, 11 on logistics. So there is a lot of things here that people don't need to be disturbed about, because there is no suitable recipients, or we know we're unable, we don't have a bed available. So therefore, we can then deal with those offers without disturbing anyone, allowing the surgeons and physicians to sleep. And just to add, and I might get some grief for this tomorrow, but our physicians don't respond too great at 3 o'clock in the morning when you ring them up. You get a much better response from a surgeon, bizarrely. So let's have a look at our players. So in the red corner, we've got the gunslinger, aka the surgeon. Little to no knowledge of the recipients, but are mastering their craft of surgery, so we need them. They come and do what they've been hired to do, and then they ride off into the sunset. Job done. In the blue corner, we've got the sheriff, aka the physician. Now, they have a really good knowledge of all the patients on our waiting list, but they need the gunslinger to come and do their surgery. They're responsible for the long-term care, and they're as surprised as the patient when they get informed that there's been a transplant. So you need somebody that brings all this together, someone efficient, someone organized. Enter the nurse, enter the transplant coordinator. We are here to make sure that these 2 parties each get informed and are up to date with everything that needs to go on. In seriousness, when you look now, you look at the things that you want as the 3 C's of a seamless allocation, and you're looking at setting a set of guidelines that can improve the consistency, continuity, and the coordination, decision-making, and patient care. That's what we're here for. The guidelines that we get form a skeleton, and it's up to us to flesh this out. And the transplant coordinator in this is the brain. We're running and coordinating clinicians' activities with directions across multiple care settings. We're able to maintain dialogue and communications between all parties. And we can identify the parameters that need to be achieved or maintained. The need for coordination is the complexity of the transplant scenario. So we are there, and that is our sole purpose. We're not distracted by anything else. The coordinators within the decision making, we're able to rationalize the information that's been given to us. We are there to help the decision makers get to the best decision. So we can find the salient points. We can wade through the documentation that we get sent at 2 o'clock in the morning to see what's there. And we've got no undue influences, or we may mitigate any undue influences. And one of the aims of this protocol-based care is to try and simplify and streamline clinical decision-making. We all want everything more simplified and make it more straightforward, especially in the middle of the night. So by us making these decisions, or being part of making these decisions, it can provide a much smoother passage, a smoother process for transplantation. Our job is not necessarily to make the final decision, but it's to try and ensure that the right decision is made. Now, this could involve us. So I'll come on to this one. Sorry. Why the coordinator? We're never scrubbed. We are always available. We're never in a procedure. If we are in clinic, we can get up and walk out of it. You guys are stuck there with it. You're there with the patients. We can try to ensure that we're using the hospital and the consultant time in the best and most constructive way possible, whether that be sleeping or directing them towards good offers. we can escalate and liaise and discuss offers with respiratory consultants, the physicians, when it's deemed appropriate, and that would be either when we have concerns, whether the surgeon has concerns, and we often double consult with a physician as well as a surgeon. We are able to broker the care between between healthcare professionals and other organisations. So we've built up good relationships with many of our donating hospitals and other procurement teams that we work with. And we're able to interface with the patient at any given time. We are their first point of call. We speak to all of our patients on a monthly basis that are on the waiting list. We either see them in clinic or we're in telephone contact with them. We are the face of the transplant. There are multiple surgeons. There are multiple consultant physicians. There are registrars that they will see in clinic. The most consistent thing that they see is the nursing team. But really, it's about the dream team. It's not one person's job. So you need a surgeon who is singularly visualized on what he needs to do. You need the physician who is also focused on their role in the team. But you cannot do it without the coordinator who's got a bigger pair of eyes to be able to see everything that's going on and bring everything together and try to make it a good collaborative effort with a good outcome for all involved. Thank you very much.
Thank you, Paul, for making that compelling and entertaining presentation for the role of the coordinator. Next, well, I guess before I move on to the next presenter, we've discussed the current practices, and now to give us a glimpse of what is perhaps the future is Dr. Alex Gimson from Cambridge in the UK. Dr. Gimson is a transplant hepatologist, but has an interest in the role of artificial intelligence and machine learning. And so he will give us a presentation on the future.
Thank you, Ramsey, and thank you to the Society for asking me to come and talk. This is my first time at this society, and I wasn't quite so aware as to how combative cardiothoracic teams are, which we're a very gentle group in liver transplantation. I have to assure you of that. So I'll try and respond to some of the comments that have been made already. So I'm going to discuss artificial intelligence and machine learning. And clearly, I'm a transplant physician, but I've dealt mainly with liver transplants. So I'll be discussing this mainly from the perspective of the liver transplant. But I will be looking more at the scope and the ambition of artificial intelligence and where we think it will take us in the future. I think there's no question that it is going to be a major factor in the future. Before I start, I want to thank a number of my colleagues, both at the Cambridge Centre for AI and Medicine and also some various statisticians at NHS Blood and Transplant, who are the regulatory authority here in the United Kingdom, for the help there. So I'm just going to go back a little bit. What you've been discussing in the previous presentations is what statisticians would call conditional average treatment effects. That is, when we say that, and you put someone on a lung transplant waiting list, it is because you think that their chance of dying is, on some score that you have used, a certain figure. That figure, in standard statistics, is called a conditional average treatment effect. Although you may have an average, for any one score, there is a whole range of patient outcomes. So in this slide, I've shown you a survival score you use in the United Kingdom end-stage liver disease score. If your score's 49, that is the average survival would be a 10% mortality at 1 year. But that includes some patients over here, patient A, who have a lower survival, and some patients here who have a higher survival. It averages all the patients' survival with that score. And for that reason, it's extremely inaccurate. What artificial intelligence is trying to do with the techniques I'm going to be describing is looking at individualized treatment effects. is by using new methodologies to identify exactly what patient A survival is and what patient B survival is, which is going to be different from the average for the whole group. So all current organ allocation systems to some degree depend on survival predictions. In the United States, for livers, they use a MELD score, which is a composite of 3 laboratory parameters. In the United Kingdom, we transplant livers on the basis of your net life years gained. This is an extremely complicated score. The original score had up to 17 different factors with multiple interactions. And on the basis of that, an organ is allocated to you. And I appreciate that there is a long allocation score used in the United States as well. Newer machine learning methodologies use causal inference to assess the prognosis at an individual level. Some, and I've just put a paper here you might want to look at, Lancet Digital Health, which use a deep learning technique, and what we have been using, which are these individual treatment effects, which I'll describe in a bit now. So we've tried to ask ourselves the question, can newer machine learning methodologies devise better decision support tools? And I emphasize that these are decision support tools, and I don't mind whether they're used by a surgeon, a physician, or a transplant coordinator. We're interested in a decision support tool, not who's making the decision. What we tried to do is to look at whether we could develop a donor organ offering sequence. So you would develop a sequence of patients, all of whom are offered the organ in turn. We want that organ offer to be interpretable. That's absolutely crucial. So you understand why the organ was offered to patient A rather than patient B. And, which is just relevant to what our last speaker was telling us about, I'm also going to show you a methodology where we can sense check clinical decisions that physicians or surgeons make about a donor offer, because there's such a high rate of clinical variation in transplantation. So there were 3 platforms, which, and these are all published, which you can look at here. Which we have developed, and I'll go through each one in turn. So Orgonite is a platform which can calculate transplant benefit by individual treatment effects. So this platform we have shown, does give improved survival estimations. I can't, in the short time I've got available, go through all those results, but it improves your survival estimation without a transplant and improves your survival estimation to a matched donor. Crucially important, and I think the 2 first speakers alluded to this, the matching donors is critically important, and the individual that is the best match isn't necessarily the best patient to be given that donor organ. The reason for that is the patient who may be second in the sequence may have a very, very low risk of receiving a better organ before their chance of dying. So in order to match organs, you not only look at who it is matched best with, but what happens to all the other patients who it is not matched with, and what are their chances of surviving until they receive an optimal organ. So in this platform, Orgonite, we were able to calculate for every patient on the list what their optimal organ was, what the scarcity of that organ was, and what their risk of getting that organ if they waited a little bit longer. Allocation by Orgonite was demonstrated to reduce deaths prior to and after transplantation compared to our current organ allocation systems on the basis of logistic regression. We did this study, as you can see, in the middle of COVID, and we actually also noted that this methodology was much more robust, particularly during reduced organ supply, as occurs during pandemics. So that, in short, was Orgonite. We were then produced another platform, which is what we've referred to as OrganSync. This was a platform where we clustered organs, donors, into what we call organ families with a similar outcome and paired them to recipients of a similar recipient family. And you can, from that, calculate what are the characteristics of those families. So these results are interpretable. Not all artificial intelligence is what we refer to as a white box. Vast majority of them are black boxes. You can never understand quite why they've made the decision they have. These new methodologies are, for the first time, a white box. This optimizes the trade-off between waiting time, waiting for another optimal organ, and your expected survival time. And looking at both the UNOS data from the United States and our United Kingdom NHS registry data, apologies, we were able to show that both deaths on the waiting list was lower. This is in a percentage, it was minus 3.5% lower, minus 4% lower in the UK. And more importantly, the added life years, we're looking at transplant benefit, the added life years increased by 13% in both the UNOS and the UK registry data. So that's the two methods of trying to match and produce outcomes. So I'm just going to quickly mention one more thing which may be of interest to you, and that is, as you'll be aware, the way in which organs are declined does have a significant impact on waiting list mortality. This is a study from the United States, again, where they showed that the acceptance rate of organs was related to the waiting list mortality in each of those transplant centres. In the United Kingdom, looking at organs which subsequently get transplanted, particularly for DCD organs, there is a range of between 20% acceptance rate in one unit and an 8% acceptance rate in another unit. There's vast range in clinical decision-making with respect to organs which are subsequently successfully transplanted. We wanted to ask ourselves the question, can we use machine learning to identify what are the drivers for that clinical decision-making? So we tried to use this technique called inverse learning, where you identify recipient and donor characteristics associated with either the acceptance or the rejection of a specific donor. And then we looked at it at both the unit level and the instance-wise level for individual organs. And you can do this. And so we can get graphs like this, which show you for a particular organ, what were the factors which was related, the program having learned how people are making these decisions in the past. What are the factors which were affecting the decision in either a positive or a negative way at the instance-wise level, and then, and I'm sorry to have to rush through all this data so quickly, also at a population level. This is a proof of concept, and we already know that that donor age, increasing donor age, has a negative impact. But using this machine learning, inverse learning, we were able to demonstrate that whether it was a local donor or a donor age, were having these impacts. We were also able to show that if you compare two different centres, we know, for instance, in both these centres, A and B here, that donor age does affect acceptance rate, but the level at which that was happening was different in the two units. Similarly, in these two units, the rate at which the donor transaminases were impacting their decision to accept or reject an organ was different between the two units. And so we think these may be really important ways that we can try to demonstrate to units or people making decisions exactly what the consequences of their decision may have been driven by. So last couple of slides quickly. I'm just going to finish with some caveats and cautions. As I'm sure you're aware, all algorithms have biases, and I know there's been a lot recently written about artificial intelligence having biases, but it's not just artificial intelligence that has biases. All algorithms have biases. The problem is that as your algorithm gets more accurate, it usually magnifies the bias. We have to be really careful how we address that, and that is because of the way that our databases are structured. Biases occur at multiple levels in the decision-making process of these databases. There are numerous limitations, as I'm sure you're aware, to registry studies, which is what ours are using the UNOS data. whether it's representative sample, missing data, and the quality of the data. It's also quite complicated in doing these studies when trying to phenotype complex patients. Certainly in liver disease, complex patients often have multiple diagnoses, and how they are coded is a major issue. And as many people are now identifying, that one of the problems with many of these AI methodologies is that as accuracy increases from a database, generalizability, in other words, how it can be transferred to another database, may diminish. We don't know. That is yet to be proven. So here are my conclusions. Conditional average treatment effects. You're going to have to get away from conditional average treatment effects, and artificial intelligence is there to help you do that. They have these new methodologies, individual treatment effects. We can now address optimal organ donor organs and their scarcity, and so we feel that AI is going to help clinicians both in offering an organ to the clinician to make the decision, but also helping him when he's made that decision interrogate whether he has made a right decision or in fact a wrong decision. I'll leave it at that. Thanks.
Thank you, Alex. That was a terrific presentation and overview of the potential role for AI in organ transplantation and donor and recipient matching. Very intriguing. Hopefully that's the future. Everyone should be able to see a poll of who won the debate, so please enter your choice. I will point out that the webinar will be posted on YouTube sometime next week, and all participants who've entered the webinar will receive a survey by email. So please respond to that survey when you do get it. And we have a few more minutes remaining, and so I would like to open up to our speakers. If anyone wants to make a final comment or rebuttal, please do so now.
So perhaps we've got a question in the chat here from Brian. So Brian, from our first speaker, do you want to ask the question yourself? You're there. There you are. I can see you.
Yeah, and I'm happy to do that. So Dr. Gimson, thank you for your talk. That was very enlightening. I think there's a huge role for AI and machine learning for a lot of these complex problems. One thing that I've struggled with, particularly around how to think around in a active donor resuscitation for a lung donor, how do the algorithms account for things that are dynamic, that may change on a hour-to-hour intraoperative basis? Liver and kidney are pretty static, right? You get the lab values, you get a biopsy, it's a percent of steatosis, and you can put that into I think you could put that into an algorithm pretty easily.
Yeah. Okay, that's a great question. And first, we've not done these studies with with a lung or cardiothoracic database, but just to reassure you, there are now time series data to methodologies for using variants which change over time. So, I mean, this is a very active topic at the moment, but I can reassure that. So machine learning aficionados have got methods for looking at time series data, which can look at dynamic changes.
Can I ask a question again on the AI topic? Because I think the world of AI is changing very, very rapidly, and we're all seeing the emergence of all sorts of AI applications like Sight and ChatGPT, etc. One of the practical issues is about implementation, particularly within a sort of infrastructure such as the NHS. Obviously, you've been working within the NHS within liver transplantation. How has it been to roll out the project like this, and how well is it taken up by clinical teams? What are the kind of practical hurdles to sort of getting to a place where AI really does have a role in clinical practice rather than within the research infrastructure?
Sure. Well, let's be straight. I mean, we're doing these studies on databases, and they are, at the moment, it's a moment of proof of concept. So nowhere, to my knowledge, is allocating organs anywhere on the basis of AI. I think it will not be quick. You may be aware I was involved in the group that introduced transplant benefit as a score for liver transplantation. That I think in total took us 8 years. Hopefully it won't be as long for that, but I think there are enormous regulatory hurdles to get over that the MHRA will want, and there have already been suggestions that you will have to do a clinical trial. There's a whole interesting area of how you do clinical trials in artificial intelligence, and how you do trials of allocation algorithms. So I think in my view, it's going to take us at least 5 years before these are involved.
Thank you. And then another question I've got, if anybody's got questions, please do put them in the chat. Otherwise, I shall carry on asking my questions. Greg, this one's for you. I already asked you one about marginality and how that affects ITU stay. But I think a lot of what Alex, you've been saying in the way that AI can be useful was really paralleled and echoed actually what you were saying, Greg, about the entire patient journey and understanding the complexity of the entire waiting list, matching the organ with patients, knowing that the next patient on the list who may not be the appropriate patient has got those very high HLA antibody levels and therefore won't get another opportunity. I think there's some real parallels in that. I'm wondering what your thoughts are on the AI story.
I'd actually just by chance just put that in the chat that I think that the cross matching is perhaps the place I could see AI where we're getting where it's a very complex puzzle that it's very hard for us to get our heads around the risks. We've sort of got we're actually working ourselves off a red zone, yellow zone, brown zone, and green zone which is safe on the different numbers you get from the cross matching, the MFIs, the unacceptable answers and stuff. And I would have thought that would be where it's most useful for us, because that is a sort of a black box out there that troubles us, trying to work out, is this the best the patient could ever get? And they will never get it again, or is this 50% and they'll get another one? So the combination of sort of like a panel reactive antibody result plus in real time how this would relate to the patient's risk. So I think AI, that's where that's my takeaway, that AI would work there.
I think I'd agree with that. I think it is exactly those complex permutations of working out the donor recipient matching with all the parameters that you mentioned, and then trying to calculate for that particular individual, what would their optimum donor be? How long might they have to wait for the optimum donor? What's their chance of dying before they reach that optimum donor? And what's then the benefit? I mean, it's a gambler's choice. Do I stick or do I twist?
Absolutely. Okay, so we've got another question coming in from Eric Verschuren. Question for you, Dr. Whitson. The problem is how to accept a marginal lung for a high-risk patient in a time when there's a lack of capacity, lack of organs availability. How do you manage that situation?
Yeah, so I think that my response to that one is going to dovetail on my response to Dr. Egan's comment. And maybe something I put in the chat, that I think the pulmonary community in general should push to have surgeons be more involved, because what I'm hearing is that most of your groups or surgeons are not that involved in the peri-op and post-operative care, and I think that's an opportunity where we could do better. I think we've got a very good collegial relationship with our pulmonary colleagues here, and have had good outcomes from there. And thinking about the comment a couple ones back from I think it was Dr. Livy. We did something similar when we changed our first donor call to our pulmonary group. Our acceptance rate went up because we didn't have a ability to say no, and it was easy, and it is a hybrid model here that works quite effectively. But to your question, I think the thing that we do is have a liberal use for EVLP and work really hard to come up with alternative strategies of either moving the donor OR or what we can manage here. We have, I think, been very progressive, and I think most, maybe it's going to come into bigger centers, but progressive around what ischemic time really means. and have a pretty low threshold for using prophylactic ECMO, because majority of our cases are done on VA or VV ECMO intraoperatively. We find that the patients have a more smooth intraoperative course. It's less shenanigans with our anesthesia colleagues. And so we've already bought the morbidity of putting somebody on ECMO and or having any degree of marginality and gases coming out of leaving them on. And so that's allowed us to push some of those ischemic time windows. But we do a modest amount of EVLP, and I think that would be my first line of how to manage a good match if there's not operating room or surgeon capacity.
Eric, does that answer your question?
Well, I was also thinking about when you know that this patient will block your intensive care unit for another 2-3 weeks because you have a very pulmonary hypertension high risk patient, and that'll mean you can do cardiac thoracic surgery, bypass surgery for the next. I mean, lung transplantation can block a bed for 2 weeks, and usually a bypass operation is only two days. So.
Yeah, at least here, that's something we just deal with. I think we've had a lot of growth and buy-in from the administration it's not ideal, but they'd rather us do transplant than do a coronary. So I mean, they want all of it. I mean, administrators always do, but I think the inherent things with transplant that are not as readily available, that there's more willingness, and maybe that's just the good working relationship we have with our administration, is that they would rather us do the transplant and deal with the downstream more effectively than not do it.
I like your answer, but it's not the answer in all centers.
No, I acknowledge that. I acknowledge that.
Okay, thank you. I think we're just at the timeline, so I'll hand back to Ramsey.
Thank you. That was a terrific webinar, I think. I want to thank all of the speakers and everyone who was engaged with asking questions. I will take a minute to announce the poll results, which showed that the pulmonologist, Dr. Greg Snell, was the winner at a 52% of the choices. Now, I suspect that there's a big bias here, but nonetheless, thank you all. And I suspect that everyone is aware and understands the role of AI, but is scared of it. So I think that's the future, and we'll have to wait and see. But ultimately, we all recognize that, all kidding aside, this is a team effort, and we all recognize the important contributions of every member of the team, because transplantation is truly a multidisciplinary approach to the care of very sick patients. So we all recognize that it's a surgeon, pulmonologist, coordinator, respiratory therapist, and so on. So thank you all for an excellent webinar, and we look forward to seeing you at the annual meeting in April.
Thanks, Ramsey.
Thank you.
Thanks, Ramsey.
Thank you.